If you're a runner, you know the exact feeling. I
Mm.
mean, the sheer physical urge to just lace up your shoes, step out the front door, and, hit the pavement.
Oh, absolutely. It's a mental release just as much as a physical one.
Right. And if you've recently had a baby, that urge to sort of reclaim your body, to feel like again, it can be incredibly overpowering.
Yeah, you just want to get back to your baseline.
Exactly. But then you take those first few hopeful strides and suddenly your body it isn't responding the way it used to. You might be experiencing something nobody warned you about, like unexpected leakage or a dragging heaviness in your pelvis, or even sharp localized pain.
Which is a completely disorienting experience for so many people. I mean,
Yeah.
you were crushing miles before, and now a light jog feels like the structural integrity of your body has been fundamentally compromised.
Yeah, compromise is the word.
And the frustration that comes with that is very real. It's often very isolating, too, because, well, it just isn't talked about openly.
Okay, let's unpack this. Because today we are answering one massive, critical question. Does lacing up your running shoes too soon after having a baby actually cause permanent mechanical damage to your pelvic floor?
The big question.
Right. Specifically, we want to figure out if a rapid postpartum return to running can cause long-term mechanical breakdown of sub-urethral support tissues. To get you the answers, we are diving deep into recent physiotherapy guidelines, long-term tracking of postpartum exercise, and the granular biomechanics of the pelvic floor.
It's a lot of ground to cover.
It is. So to start this deep dive, we really have to look at the sheer physics of what happens to a postpartum body in motion.
And physics it's the perfect place to start. To answer whether running physically breaks down those tissues, we first have to understand the normal, healthy function of the pelvic floor.
Okay, set the scene for us.
So picture this structure as a dynamic, muscular hammock at the very base of your pelvis. Ordinarily, this hammock has a highly tuned reflexive function. It acts like an intelligent shock absorber that anticipates impact before it even happens.
Before it happens, like it knows you're going to land.
Exactly. Just a millisecond before your foot hits the ground while running, the central nervous system sends a signal. Those muscles automatically engage, tightening up to keep your internal organs supported and your urethra firmly closed.
Wow. So it's pre-bracing for the hit, like completely subconsciously.
Yeah.
The brain knows the foot is about to strike, so it locks down the hardware to protect the internal organs.
Precisely. But in the postpartum period, that automatic reflex is significantly altered.
Because of the trauma of birth.
Right. After a vaginal delivery where the tissues and nerve pathways have been stretched way beyond their normal limits, or after a long labor or an instrumental delivery, that pre-bracing reflex is often delayed. Sometimes it is absent entirely for a period of time.
Oh, wow. So the shock absorber is just offline.
Yeah, exactly. And when you combine that delayed neural reflex with the intense biomechanics of running, you have a recipe for trouble. I mean, running isn't just walking faster. With every single step you take, running generates ground reaction forces of 1.6 to 4 times your body weight.
Wait, 4 times your body weight?
Up to 4 times, yeah.
With every single step. That is a massive amount of kinetic force traveling up the foot, through the leg, and straight into the pelvis.
And when that kinetic source hits the pelvis, it causes a violent spike in what we call intra-abdominal pressure, or IAP.
IAP, okay. How does that affect the hammock?
Think of your abdomen like a fluid-filled balloon resting right on top of that muscular hammock. When you land a heavy running stride, you are essentially squeezing the top of that balloon.
Which pushes everything down.
Right. If your pelvic floor reflex is delayed by even a fraction of a second, it cannot push back against that sudden downward pressure. The downward force literally overrides your urethral closure pressure, physically forcing urine out.
Okay, so that is the mechanical definition of stress urinary incontinence, or SUI.
Yeah.
It's an issue of pressure and timing.
Yes, exactly. But it's not just timing. The structural foundation of the pelvis has also been physically altered by pregnancy itself.
Right, because the hammock isn't just missing its cue. The actual fibers of the hammock have been stretched or even torn.
The connective tissues are undeniably compromised. During pregnancy and delivery, the levator hiatus, which is the main opening in the pelvic floor muscles, physically widens to allow for childbirth.
Right.
The muscle fibers themselves can suffer micro tears or even macro tears. And if a woman had a C-section, well, it's a completely different but equally significant kind of structural trauma.
Because of the incision through the muscle.
Through the fascia, actually. The abdominal fascia is the thick connective tissue that was surgically cut to deliver the baby. And our sources show it has only regained about 50% of its original tensile strength by the 6-week postpartum mark.
Only 50% is 6 weeks.
Yeah. And even looking further out to 6 or 7 months, that fascia is still only at 73 to 93% of its original load-bearing strength.
So returning to high-impact running at 6 weeks is essentially like driving heavy trucks over a newly built bridge while the concrete is still wet.
That's a great way to put it.
Like, the structure is physically there, it looks like a bridge, but the load-bearing capacity just isn't ready for heavy
The
traffic.
concrete is absolutely still wet. And sending a 4-ton truck over that wet concrete, which is the 4 times body weight impact of running, is exactly what leads to the mechanical breakdown of those sub-urethral support tissues.
Because it's too much load too soon.
Yes. Every time that foot strikes the pavement without the proper structural integrity and reflexive timing, those sub-urethral tissues are being stretched beyond their current threshold. You aren't just experiencing a temporary symptom when you leak during a run. You are actively overstressing vulnerable tissues.
And I imagine that adds up.
It does. Over time, that repetitive stress without adequate recovery can result in persistent stress urinary incontinence, or even lead to pelvic organ prolapse down the line.
Okay, so the mechanical trauma is crystal clear. We have a weakened structural bridge taking on maximum impact forces before the materials have cured. But usually when the body sustains physical trauma, like a sprained ankle or a torn muscle, it immediately sends a biological construction crew to fix it. Why doesn't that happen here? Like, what is preventing these postpartum tissues from just healing up quickly?
Well, that brings us to a fascinating hormonal plot twist, and it is a relatively new area of intense clinical focus. There is an entirely separate chemical layer that prevents these specific tissues from healing quickly.
Chemical, meaning hormones.
Yes, especially for mothers who are breastfeeding. Clinicians have introduced a newly coined term for this. It's called genitourinary syndrome of lactation, or GSL.
GSL, okay, what does that actually mean?
It explains the why behind the delayed healing, and it all comes down to a battle within the endocrine system. To produce breast milk, a mother's body requires sustained high levels of a hormone called prolactin.
Right, prolactin makes the milk.
But prolactin is fiercely territorial. Its high presence actively suppresses the production of estrogen and androgens in the ovaries.
Oh, wow. Which creates what do they call it? A hypoestrogenic state.
Yep.
Essentially, lactating women are temporarily put into a hormonal environment that mimics menopause.
They are. And this is a critical piece of the puzzle because estrogen does so much more than regulate the reproductive cycle.
What else does it do?
Estrogen is the primary architect for maintaining the thickness and elasticity of the vaginal wall, regulating natural lubrication, and most crucially for a runner's recovery-boosting collagen synthesis.
Ah. And collagen synthesis is tissue repair. It's the literal building blocks of the bridge.
Precisely. Estrogen provides the fundamental chemical instructions for the body to rebuild structural tissue. Without sufficient estrogen circulating in the bloodstream, the suburethral tissues literally lack the chemical building blocks required to repair the microtears caused by the trauma of birth.
So the body is just chemically stalled.
Exactly. If the body can't even keep up with the baseline repairs from delivery, it certainly cannot handle the high-impact microtrauma of early running.
Wait, so the very biological process of nourishing a newborn producing milk is temporarily starving the mother's pelvic tissues of the exact hormone she needs to rebuild her own structural support.
What's fascinating here is that biology is heavily prioritizing the infant's immediate nutritional needs over the mother's long-term structural repair.
That is wild.
It is a profound physiological trade-off. The body deems milk production essential for the species' survival, while repairing the mother's pelvic floor is deemed, well, secondary.
A secondary concern for survival.
Right. And this vulnerability is compounded by another hormone called relaxin. Relaxin does exactly what it sounds like. It increases joint laxity and loosens ligaments during pregnancy to allow the pelvis to widen for birth.
So everything is looser.
Yes. But if you are breastfeeding, relaxin often remains elevated in your system long after delivery, keeping your ligaments hypermobile. So your joints are unstable, your tissues are physically weak, and your body is chemically blocked from quickly repairing them.
I mean, that is a staggering biological double whammy right there.
Yeah.
It really reframes the whole idea of postpartum recovery. It's not just a matter of resting your muscles. Your body is operating under a completely different chemical directive.
It really is.
Is there anything that can be done about the hormonal side of this, like treatments?
Treatments do exist for the symptoms of GSL. Pelvic floor physical therapists and medical doctors frequently recommend conservative approaches, like hyaluronic acid moisturizers to help with tissue integrity.
Okay, that makes sense.
They might also prescribe low-dose vaginal estrogen. Studies have shown this is highly localized, safe, and unlikely to systematically affect breast milk supply.
That's good to know.
Yeah, and there are also newer non-pharmacological options being studied, like functional microablative CO2 lasers designed to improve tissue thickness and blood flow.
Lasers. Wow, science is amazing.
It is. But any treatment plan has to account for a major nutritional caveat that often derails postpartum runners, which is REDS, or relative energy deficiency in sport.
Ugh, alrighty, yes. Here's where the calorie math just doesn't add up for a lot of active mothers.
No, it really doesn't. Breastfeeding burns a massive amount of calories, anywhere from 500 to 700 extra calories a day just to produce milk.
Mm.
Running also burns a massive amount of calories.
Right.
So if a mother's nutritional intake doesn't aggressively meet those compounded extreme energy demands, the body enters a deep caloric deficit.
And what happens then?
In an energy deficit, the body operates like a triage unit. It shuts down any non-essential physiological functions to keep the heart beating and the milk flowing.
Wow.
One of the first things to get shut down in a triage scenario is structural tissue recovery and protein synthesis. You cannot rebuild a broken bridge if you aren't providing the raw materials and the energy to pay the construction workers.
Which brings us to a really difficult crossroad for anyone listening. We have established the physical trauma, the mechanical vulnerability of the wet concrete, this chemical roadblock of low estrogen, and the energy demands of RDS.
It is a lot to manage.
It sounds incredibly daunting. In fact, one major data point really stands out from the sources. High-impact exercise has been found to increase the risk of pelvic floor dysfunction by 4.59 times compared to low-impact exercise.
That's a huge jump in risk.
So looking at all of this evidence, a logical person might conclude that avoiding exercise completely is the safest bet. Like, just stay off your feet entirely for 6 months to let the bridge cure, right?
Well, this raises an important question, and it's a very common conclusion people jump to. But the data reveals a surprising paradox about human physiology.
Oh, what is it?
Complete inactivity is actually highly detrimental to tissue recovery.
Wait, really?
Yeah.
Even with the wet concrete, the micro tears, and the total lack of estrogen?
The research bears this out beautifully. A major longitudinal cohort study recently followed 504 postpartum women from 3 months to 12 months after giving birth. Researchers divided these women based on their exercise habits to see how their pelvic floor tissues recovered over a year. They found that the non-exercisers, the women who avoided physical activity to rest their bodies, actually experienced a measurable increase in the severity of their stress urinary incontinence at the 12-month mark.
Hold on, the people who did absolutely nothing got worse?
They got worse because tissues atrophy without use. The human body operates on a use it or lose it principle.
Even when healing. That is so counterintuitive.
Right. Conversely, the women in the study who engaged in minimal, low-impact exercise saw their incontinence severity decrease and their overall pelvic floor strength improve over that same first year.
Okay, so movement is medicine, but high impact is the poison.
It all comes down to how force is applied to the healing tissues. Another fascinating study by Middlecoff and colleagues looked closely at the exact relationship between peak exercise loading and pelvic floor damage.
And what did they find?
They found that peak loading during exercise wasn't perfectly correlated with tissue breakdown, meaning it's not just the sheer absolute force of the exercise that determines who gets injured and who doesn't.
Then what does?
They suggest that intrinsic factors play a massive, undeniable role. For example, genetics account for roughly 50% of the variability in urethral mobility among females.
Wait, 50%. So half of your risk for leaking while running or experiencing tissue breakdown is just dictated by the genetic lottery of how your connective tissues were built?
Exactly. Some runners are simply genetically predisposed to a greater loss of structural support than others, regardless of their pelvic loading exposure or how careful they are.
That's incredibly frustrating, but also maybe a little validating for people who feel like they did everything right but still have issues.
Absolutely. But the universal takeaway for every runner is this. It is not the act of exercising that destroys the suburethral tissues. It is improper load management.
Load management.
Yes. Muscles and connective tissues actually require some mechanical loading to heal, remodel, and build tensile strength. But subjecting them to high-impact running without building a foundational base of core and pelvic strength first is what causes the long-term mechanical breakdown.
Knowing that gradual loading is the cure and premature high-impact loading is the poison, how do we practically apply this to someone's life? Because traditionally, a woman goes to her OBGYN at exactly 6 weeks postpartum.
Right. The infamous 6-week checkup.
Yeah, the doctor does an exam, says everything looks good, and clears her for exercise. But based on the biomechanics we just walked through, that 6-week clearance seems like a dangerous miscommunication.
It is a massive systemic failing in how the medical community communicates postpartum health. The new clinical guidelines from top physiotherapists around the world are crystal clear on this. The traditional 6-week OBGYN checkup is not a functional clearance for high-impact sports.
It's just not.
It was never designed to be. It is merely a check for basic medical healing.
Meaning what, exactly?
The doctor's checking that your uterus is shrinking appropriately to prevent hemorrhage. They are checking that any incisions or perineal tears are medically closed, and they are ensuring there is no infection.
So they are looking for emergencies, essentially.
Yeah, they are absolutely not checking if your deep core stabilizers and pelvic floor can handle 4 times your body weight hitting the pavement for 3 miles.
So the 6-week bounce-back myth needs to be completely scrapped. If 6 weeks is just a check for infection, what is the actual timeline for running?
Modern clinical guidelines state that the absolute earliest a postpartum woman should return to running is 12 weeks. 3 full months of recovery.
12 weeks.
And we need to be very clear here. 12 weeks is not a green light to just go run a 5K on a Tuesday morning. It is simply the earliest point to begin a highly structured, progressive return-to-run program.
Right. And the guidelines also outline a very specific physical checklist you have to pass before you even attempt that first jog at 12 weeks.
Yeah.
And looking at the specific movements, it makes total sense why they test them.
Oh, the checklist is crucial. A runner must pass specific load impact tests to prove their tissues have regained the capacity to handle running stress. First, you need to be able to walk for 30 minutes completely symptom-free.
Symptom-free, meaning no leakage, no dragging heaviness, and no pain.
Exactly. Then you need to be able to balance on one leg for 10 seconds.
Which tests your deep pelvic stability, right? Because if you can't balance on one leg standing still, your core muscles aren't firing correctly to stabilize your hips when you are actually in motion.
That is exactly the reason for that test. Next, you have to perform 10 single-leg squats on each side, which proves your glutes and hip stabilizers can manage your body weight without relying on compensatory muscles.
Okay, that sounds tough but necessary. What's next?
Then you have to hop on one leg 10 times in place and do 10 forward bounds, all completely without symptoms.
Because running, biomechanically speaking, is just a rapid, continuous series of single-leg forward bounds.
Exactly right.
If your pelvic floor can't handle 10 forward bounds in your living room without overriding urethral closure pressure, you definitely cannot handle 2,000 pounds on the pavement.
You really can.
What actually happens if someone ignores this checklist? Say they feel generally fine, they skip the balance tests, and they just push through a weak core and glute complex to get their miles in.
Well, if you push through without that foundational neuromuscular stability, your body inevitably compensates. It shifts the impact load away from the weak muscles and dumps it onto other structures, usually the joints and ligaments.
And what does that do?
The guidelines warn that this compensatory stress frequently leads to a condition called osteitis pubis.
Osteitis pubis, that sounds painful.
It is a severe, highly painful inflammation of the pelvic joint, where the two halves of your pelvis meet in the front at the pubic symphysis. When your deep core isn't stabilizing the pelvis, the two halves shear against each other with every running stride.
Ugh, shearing against each other. That is a terrible image.
It is incredibly debilitating. It's painful to even walk, and it can sideline a runner for many months. Also, a quick note for the multitasking parents out there. Running with a stroller changes your biomechanics entirely.
Oh, because of the posture.
Yes, it forces you to hinge forward and removes your natural arm swing, which requires even more core stability to prevent injury. The guidelines heavily recommend waiting until at least 6 to 9 months postpartum before introducing stroller running.
Wow, 6 to 9 months. But here's where it gets really interesting, though. You don't have to navigate this 12-week waiting period or these physical tests alone in your living room.
Not at all.
The latest research is screaming from the rooftops about the effectiveness of pelvic floor physical therapy, or PFPT. To be clear, this isn't just doing some kegels at traffic lights. This is targeted, supervised neuromuscular rehab.
Yes, and the statistics are incredible.
They really are. Studies show that engaging in supervised pelvic floor therapy starting around 9 weeks postpartum reduced urinary incontinence rates from 82% down to 57% by the 6-month mark. It also reduced the odds of developing pelvic organ prolapse by 56%. It is the ultimate game changer for athletes trying to get back to their sport safely.
It truly is the gold standard of care. A specialized pelvic floor physical therapist can actually measure your baseline tissue strength, assess your reflex timing to see if the hammock is pre-bracing correctly, and prescribe specific progressive loads.
So they help cure the wet concrete.
Exactly. They safely rebuild that wet concrete into a reinforced bridge. They treat the postpartum runner as exactly what they are, an athlete in a dedicated rehabilitation phase.
So what does this all mean for you? Let's bring it back to the mission we set at the start. Can a rapid postpartum return to running cause long-term mechanical breakdown of sub-urethral tissues?
Yes, unquestionably.
Between the intense physics of a delayed pelvic reflex, the ground reaction forces of 4 times your body weight, and the hypoestrogenic state of lactation, starving your tissue's collagen synthesis, premature running is a perfect storm for mechanical damage.
And perfect storm.
But, and this is the crucial takeaway, it is not a life sentence. With a minimum of 12 weeks of patience, an awareness of your body's hormonal state and calorie needs, and the guided progression of pelvic floor physical therapy, you can actively rebuild the infrastructure to run leak-free and pain-free.
If we connect this to the bigger picture, we really have to ask ourselves a fairly uncomfortable question about our cultural expectations.
Yeah.
Why does our society so heavily celebrate the bounce-back culture for postpartum mothers, when human biology clearly dictates a complex, energy-intensive rebuild phase?
That is such a good point.
Think about professional sports for a moment. If a professional soccer player tears her ACL, the entire medical community surrounds her with support. She is given a strict 9 to 12-month, structured, highly patient rehab timeline.
Right, and no one questions it.
Exactly. We expect her to rest, to rebuild slowly, and to pass stringent functional tests before she is ever allowed to touch a soccer ball in a game. What if we treated a postpartum runner with that exact same unconditional respect and structured timeline?
It would change everything.
How much more longevity could women have in their sports and in their daily active lives if we fundamentally stopped praising the 6-week bounce back?
You wouldn't drive a 4-ton truck over a bridge with wet concrete, and you shouldn't ask your body to absorb maximum impact while it is still chemically and mechanically rebuilding its foundation.
Very well said.
To you, the listener, if you're looking at your running shoes right now, know that the road isn't going anywhere. Take your time, trust your body's complex healing process, and give yourself the grace of a proper, structured rehab. Keep learning, keep moving safely, and we will catch you on the next deep dive.